Good morning, everyone. Welcome to Medicine Grand Rounds this morning. I'm Ava Kadiwada. I'm one of the internal medicine chief residents. This morning, I have the pleasure of introducing two of my friends and co-chief residents, Dr. Taylor Geisman and Dr. Rana. We will have two separate presentations this morning, and we'll save all questions for the end. But anytime throughout either of the presentations, feel free to use the chat box or the Q&A tool to send questions our way. Dr. Taylor Geisman will present first. Taylor grew up in nearby St. Charles, Missouri. She graduated with a BS in biochemistry and biology at the University of Dayton, where she graduated summa cum laude and honors with distinction. She returned to Missouri to pursue her medical degree at Washington University in St. Louis. WashU was thrilled to keep her as an internal medicine resident, where she participated in the C-STAR, the Clinical Scientist Training and Research Program. She will stay at WashU as a gastroenterology fellow starting this summer. This morning, she joins us to discuss physician infertility.
Thank you so much, Dr. Kadiwada, and thanks everyone for attending this morning. Today, my topic, like Ava said, is going to be on physician infertility, which I think has really made its way into a lot of the minds of physicians over the last few years, probably coinciding with the increasing number of female physicians. So to get started, I have no relevant financial disclosures. And my objectives for this talk, and this also serves as my outline, is to define infertility, common reasons for infertility, and the incidence in the general population, and then to give a little bit more background on common treatments for infertility and fertility preservation. I'm then going to describe the incidence of infertility amongst female physicians and the implications this has on well-being, and describe and propose ways to address fertility at institutional and national levels. Before I get started, I just wanted to give a disclaimer. So in this talk, I'm going to be primarily focusing on fertility issues surrounding female physicians. And the reason for this is because most of the data that's out there these days really focuses on females. But I do acknowledge these topics are equally as important in all other groups, including male, same-sex partner, transgender, non-gender binary, and single physicians. So let's start off with a case. So IVF is a 38-year-old physician who's coming to her OBGYN for fertility counseling. So she and her partner have been attempting pregnancy for the last 12 months, but have been unable to successfully conceive. She has a few questions for you, and keep these questions in mind moving forward through the presentation. Is this common? Did she wait too long to start trying to conceive? What treatment options are available for her? And something that comes to everyone's minds is this going to be covered by insurance? So to start off, I wanted to give an overview of infertility. So how do we define infertility? So infertility is defined as failure to conceive pregnancy with unprotected intercourse within 6 months for women greater than or equal to the age of 35, or 12 months for women under the age of 35. And why do we choose that age of 35 as the cutoff? Well, this is, I think, everyone's favorite graph where we start off with having the most number of follicles when we're born, and that steadily decreases over time. So you can see here, kind of right around the age of 35, that decrease starts to be more pronounced. And additionally, the number of abnormal eggs also starts to go up, which can lead to infertility. So this is really why we choose that age of 35. And it's more of a matter of women above the age of 35 don't have as much time to wait. Which is why it's recommended that they receive some sort of intervention or evaluation at that point. So what is the prevalence of infertility? Well, in the general population, it's about 1 in 8 couples will be diagnosed with infertility, and this equates to about 8 million women in the US. Risk factors for infertility include older age over 35, extremes in weight, tobacco, alcohol, drug use, over or under exercise, history of pelvic inflammatory disorders and other STIs, and history of irregular menstrual cycles. There is a racial disparity associated with this as well, as African American women tend to have increased rates of infertility, usually due to tubal factors, but also have lower rates of access to infertility treatments. So what are some common reasons for infertility? And I like to think of this in terms of the anatomy. So here we see female anatomy, starting off with the ovary, very common disruption of ovarian function, which includes diminished ovarian reserve over time, premature ovarian failure, PCOS, hypothalamic amenorrhea. Evaluation for this really centers around taking a good menstrual history. And in older women, to evaluate for ovarian reserve, you can check a follicle number via ultrasound and an AMH. So kind of moving down the process, the next area is the fallopian tube, and anything that really causes blockages in the fallopian tubes can also functionally lead to infertility. And this usually includes history of pelvic radiation, history of pelvic inflammatory disorders. And this is evaluated for with a hysterosalpingogram. The next area we focus on is the uterus. So anything that can cause changes in the uterus, and most commonly we think of fibroids, can also lead to infertility. This is evaluated for with a pelvic ultrasound. And then kind of the general grab bag of male factors, which really includes any abnormalities with semen or sperm, any disruption of testicular or ejaculatory function. Otherwise, we think of hormonal disorders, genetic disorders. And this is always part of the initial workup for infertility as well, with the semen analysis, where sperm concentration, motility, and quality are evaluated. And then kind of the last category is unexplained. So, you know, the evaluation's been negative and we don't really particularly have a reason why a couple is infertile. So I just wanted to talk a little bit about kind of how the breakdown in the general population goes with percentages of different causes. So if we think of couples, about 35% is due to male problems, and about 35% is due to tubal and pelvic pathology. I will say that this category of unexplained infertility is thought to probably mostly be male related, and that's because some of the testing for semen analysis is very crude, and we're probably missing other sperm abnormalities that we're just not catching on that analysis. And then if we move over to this side on the right, for women, we think about 40% is due to ovulatory dysfunction, and then the other 40% due to tubal and pelvic pathologies. So really in women specifically, ovulatory dysfunction and pelvic pathologies make up the bulk of why we see infertility. So what are some treatments for infertility and fertility preservation? And I think this is important to go through before I kind of get into female physician specific factors, just because we need to know what the options are. So the first category includes medications that can induce ovulation or superovulation. And the two most common that we think of and that are used are clomiphene and letrozole. These are medications that work on the HPO axis. They're typically first line for treatment for women with unexplained fertility or suspected fertility due to ovarian dysfunction. I will say the biggest risk associated with these medications is multiples. You can imagine that these can release cause the release of more than one egg per ovulatory cycle. And actually, if pregnancy is achieved with these, there's about a 5 to 8% risk that it's a pregnancy in multiples. The good thing about these medications is they're pretty affordable. If you look on GoodRx, they usually go for about $30 to $60 per month. And they typically have about a 20 to 30% success rate. The next category that can be considered is IUI, or intrauterine insemination. And this is a procedure which involves directly injecting pre-treated sperm into a woman's uterus. And it's typically done in combination with superovulation. This is typically used in couples with unexplained fertility or in suspected mild male factor infertility. This procedure is a little bit more expensive. It runs about $300 to $1,000. It can be higher if you're choosing to use a sperm donor, which can be another $800 to $1,000. And success rates are typically around 5 to 15%, but this can be a good option in a select group of patients. And then the final category that I'm going to talk about is assisted reproductive technology, which I'm going to spend the bulk of my time talking about. I actually had a nice video for this, but unfortunately YouTube was blocked. But the type of assisted reproductive technology we most commonly think of is IVF. In this process, just to walk through very briefly, it really begins with a woman undergoing ovarian stimulation hormone therapy for typically about 12 days. And this will involve kind of serial blood work and ultrasounds to observe egg follicle maturation, usually about 4 to 5 times in that period. Once the eggs have reached a significant size, they're given another hormone to induce final maturation. And then 36 hours later, the patient will undergo an egg retrieval. Ideally about, usually 10 is the goal eggs that are collected, but in younger women, that number can be a little bit higher. And the timing for this is key because once a woman has ovulated, those eggs are lost. So you really need to time this pretty well. The following step includes sperm preparation and egg fertilization with the sperm. And then 3 to 5 days later, after that happens and the embryo's had a chance to develop, the embryo will be re-implanted, only one at a time. There's not more than usually one implanted at any given time. And the rest will be frozen for future implantations. So you can imagine this is a pretty intensive procedure. It really involves a lot of time, a lot of hormone therapy, and it's also pretty expensive. So the cost for this is usually about $10,000 to $15,000 for the procedure itself, with an additional $2,500 to $5,000 for the medications. So keep this process in mind moving forward and think about this process, especially in terms of working female physicians too. So how successful is this? So, you hear a lot of people say, if I'm not able to achieve pregnancy by my goal, I'll do IVF in the end. But, the reality is IVF isn't a guarantee. So here we have CDC data, national data for assisted reproductive technology success rates. You can see that the success rates are higher and highest in women under the age of 35, but they're still only about 50%. And look at how these success rates decrease kind of with increasing age as well, to the point where once you get over the age of 40, the success rates are really about 10%. So I also wanted to touch a little bit on fertility preservation and elective egg freezing. So this is really the same process as IVF, except you really stop after the egg retrieval and freeze eggs for later. So in 2012, this procedure was no longer considered to be experimental by the major medical societies. And currently, and I think where we see it mostly as IM residents, is we use this when counseling patients who have a newly diagnosed malignancy or are about to undergo gonadotropic chemotherapies, major pelvic surgeries, or radiation. However, if you look at this last point, this is actually not recommended currently by the American College of Obstetrics and Gynecology as the sole purpose for circumventing reproductive aging in healthy women. And I'm going to get into some of the reasons as why that is. So similar to IVF, elective egg freezing is not considered to be a guarantee. So this is a graph looking at success rates of having a live birth with a specific number of frozen eggs stratified based on age. As you probably remember, the goal number of eggs that are achieved during an IVF or an egg stimulation is usually between like 10 and 20. Again, some older women won't even get this, but these numbers represent kind of what your likelihood is. So if we look at our most prime group, which is women under the age of 35, the number is still only about 70% if you've had one cycle of egg retrieval and have gotten 10 eggs. And you can see how substantially that number drops off with increasing age to where you get to the age of 40, the number really goes down to about 30%. So again, younger women have the highest chance of success with egg freezing of having a live birth, but this is also the population that's, odds are probably going to be able to conceive on their own. And I think the other major factor besides success rate that we think about is cost and cost effectiveness. So the cost of egg freezing is pretty similar to the cost of IVF, about $10,000 to $15,000 plus medications. And then on top of it, there's an additional $300 to $500 per year for storing the frozen eggs. So there have been studies that have created models for theoretical cost effectiveness using a decision tree analysis. And in general, they've shown that egg freezing is probably not cost effective in younger patients despite having healthier eggs. Again, as most of these patients will get pregnant on their own. However, there were a few studies that showed that there may be cost effectiveness in women in their mid-30s. Now, these models aren't perfect, as some people will argue that the rate of women actually returning to use their frozen eggs is too low to be cost effective. Previously, that number was quoted to be around 10%, but there was actually a recent study coming out of NYU that showed that number may now be as high as 38%. Another consideration, which we'll get into later in the talk, is that egg freezing isn't covered under most fertility benefits. So even if your institution has a fertility benefit, since this is considered elective, it may not be covered. So, I think my major take home point for egg freezing, this decision is really personal, and this decision really needs to be individualized to the patient. There are certainly pros of egg freezing, and there's certainly, downsides to it as well. But I think at least women having access to fertility counseling for this and being able to ask their questions and being able to take all their individual factors into play is really important. So now let's segue into infertility in female physicians. So before I really jump into the prevalence and whatnot, I want to go over some statistics on how female physicians really undergo family planning and childbearing. So in general, female physicians on average have their first child 7 years later than the general population. This was a major study published in 2016, which was a cross-sectional study of about 600 female physicians. And in general, most women here tended to have their first pregnancy around the age of 31, compared with about 24 in the general population, which we can see here with the dark bar. And you can see here, the first pregnancy oftentimes lined up pretty well with the completion of training, which on average was about 4 years after medical school graduation. So, this was an indication that women are probably, planning their first pregnancy around the time that they're finished training. There was actually a paper which I think hammered this point home a little bit more, published 2 weeks ago in JAMA Internal Medicine, which surveyed over 5,000 female physicians over 20 years in Canada. And that also found that the median age of childbirth in physicians was 32, compared to now the age in the general population was a little bit older, about 27 years old. But as you can see here, female physicians were less likely to experience childbirth at younger ages with a hazard ratio of 0.15, and more likely to experience childbirth at older ages. And I think just seeing this graph, it's pretty striking, the differences between these curves. I think, what we can say though is that eventually the curves do cross, and physicians have similar overall cumulative probability to non-physicians of childbearing. So why the delay, right? So we know that women, female physicians are waiting longer. We know that they're waiting till the end of training. So why? And this was a study completed by one of our REI fellows here, actually, Dr. Caitlin Martin. And this was a survey of about 300 OBGYN residents from top 50 programs around the country. Of all the residents surveyed, actually over 50% were stating that they were currently delaying pregnancy. And the median age that they said that they would aim to have their first birth would be around the age of 31. But when they were asked to cite reasons for why they were waiting, the vast majority, 85%, said that they were waiting because of career and education. The next two categories were financial reasons, which made up about 38% or so, and then lack of partner, which was about 25%. And their concerns are not unfounded. The reasons that they were waiting, I don't think are surprising to a lot of us. And those were mostly concerns about supportive work environment. So we can see here from the same paper published in 2016 that women were less likely to feel supported in childbearing during medical school and during training than they were after training or before medical school, which was used as the control. And there's been a lot of other studies looking at factors for this. So we know from prior studies that female physicians and residents specifically, once they come back from maternity leave, have lower overall peer evaluation scores. A lot of residents don't end up taking full leave. They say, they may not feel supported by their program, by their co-residents. And I think this is a systems level issue, right? Most residents aren't intrinsically malicious people that are, purposely feeling animosity towards each other, right? You're built into a system, and it's a little bit better here with internal medicine because we are such a big program and our coverage, isn't as hard to obtain. But when you're thinking, fellowships, smaller surgical subspecialties, who have smaller number of residents, that amount of call that people take during the maternity and paternity leave really builds up. So, I think there's system level reasons why this is the case. And I don't think that this is intrinsically due to any, maliciousness within the residents themselves. So I think the final point is people have misconceptions about their fertility. So there was a study which I really liked also from 2016, which was a cross-sectional study of 240 OBGYN, I think is the key here, residents. Almost half of the residents overestimated when their fertility started to decline. 3/4 of the residents overestimated the success rates of IVF, and only 1 in 4 felt familiar or very familiar with egg preservation. These are residents that rotate through fertility clinics that are counseling their patients on, fertility. And even the residents who do this for a living kind of have some of these misconceptions. So, what does that lead to? And I think the downstream effect when you combine women are waiting longer, mainly because they don't feel supported by their environment and they have misconceptions of their fertility, is that actually 1 in 4 female physicians will be diagnosed with infertility. And if you recall from before, that's almost double the rate of the general population, which is 1 in 8. And most female healthcare providers are diagnosed with infertility around the age of 33. And most commonly, this is actually thought to be due to diminished ovarian function due to age and ovulatory disorders. And though this is really a little bit beyond the scope of the presentation, the rates of adverse pregnancy outcomes, including preterm labor, preeclampsia, are higher in female physicians, which again is probably related due to age of first pregnancy. So what are the consequences of infertility? I think the first big area is emotional. So you have a very successful woman who's really dedicated her life to her career, who's now having to go through multiple appointments, testing, injections, serial ultrasounds, egg retrieval, which in the end might not be successful. There are obviously financial implications as well, with the cost of a single cycle of IVF can cost $20,000, and a lot of people undergo multiple cycles. There's physical consequences as well with injections, egg retrieval procedures. And this can all really lead to burnout, which is really a combination of all of those factors. And, data suggests that women in general are already more susceptible due to burnout in the healthcare profession due to gender bias and work-life integration. So you put this on top of that, and that can really lead to a lot of job dissatisfaction. So how do we address female physician infertility? And I will say a lot of the following points were addressed in a recent call to action by one of our former WashU surgeons here, Dr. Arga Gonzalez, who's now practicing at Stanford. But she had a really nice call to action that was published a few months ago. And I'm gonna take a lot of the points that she made and try to compare them to what we're doing here at WashU. So I think first is that we need to increase awareness and education about fertility. I showed you all the statistics on that single survey from the OBGYN residents about overestimating age when fertility declines, overestimating IVF success rates. There are excellent resources available from the American College of Obstetrics and Gynecology and the American Society of Reproductive Medicine, but do trainees know about them? So really, we should be including this education in our undergraduate medical school and residency curriculums. And I will say that the new curriculum in the medical school, it sounds like there is fertility counseling actually being integrated within that too. So hopefully more institutions can take steps like that to be able to include some of this education and, continue it at a residency fellowship level too. The next point that's made is that there should be insurance coverage provided for fertility support, including assessment, preservation, and management. So here at Washington University, we have a $10,000 lifetime benefit plus an additional $5,000 benefit for medications. And this is restrictive, meaning that this benefit is only covered at the WashU Fertility Center. And at Barnes Jewish Hospital, there's a $7,500 lifetime benefit, an additional $2,500 for medications. I do want to say that elective egg freezing here is not covered under either fertility benefit. And actually, when you look at fertility benefits of a lot of institutions, this is pretty much the norm. As of 2015, so this might be a little bit outdated, even though 84% of healthcare corporations had health insurance for their employees, only about 29% provided infertility services. So what about those places that aren't offering any fertility benefits? Well, advocacy works. So this was an article from 2015 where several women at the University of Michigan started a letter writing campaign to include fertility benefits for all of their employees. And this actually ended up resulting in a $20,000 lifetime coverage benefit. Looking at the subsequent paper, actually, which is pretty interesting, this investigated the results of expanded coverage. And it showed, unsurprisingly, that this increased access for really all employees and had increased utilization of fertility care. But the highest proportion of that was actually in the lower salaried women. that they had higher rates of usage after this. So I think this can also really, providing these fertility benefits can help traverse some of the economic barriers, especially for more of the underserved populations as well. So, even if you are lucky enough to have a health plan that does cover infertility treatments, again, most don't cover elective egg freezing. And as of 2019, there were only 30 companies in the Fortune 500 that did cover this. There are a few residency programs that offer discounts for elective egg freezing, but again, this is something that is not, and definitely not widespread at this point. And I think the final point that is made is that we need to offer support for students, trainees, and young faculty undergoing fertility preservation or treatment. And this includes increasing awareness, paid time off for clinical coverage for individuals having to attend appointments, procedures, mental health support, fighting the stigma, formal policies around maternal and paternal leave, and more insurance coverage for fertility and egg freezing. And I referenced this paper from JAMA Internal Medicine earlier, but I think their take-home point was really good in that this isn't going to be an easy solution, and that really we need systems-level interventions to support women who wish to have children in all of their career stages. So with that, I just wanted to end with a few more resources for infertility. The American College of Obstetrics and Gynecology and the American Society for Reproductive Medicine have awesome handouts on their webpage that not only you can use for patients, but you can use for yourself as well. AMWA is actually having a physician fertility summit in 2 weeks on June 12th. This is the Instagram posting of it. You can register here. And I wanted to say a big thank you to Dr. Caitlin Martin, who is one of the fellows in the Division of Reproductive Endocrinology and Infertility. This is a big topic that was pretty new to me too, that I don't think I've gotten a lot of training on. And she really helped me out with this presentation. Also, Dr. Kenan Omertag, who is the new division chief of the Division of Reproductive and Endocrinology and Infertility, who also gave a lot of expertise to this presentation as well. My fiance for letting me practice, Dr. Frazier, Dr. Costco, all of my co-chiefs, the APDs, all of the residents for a great year. And I am a dog mom. This is Lacey. She's really cute. Here are my references. Ava said that we'll do questions at the end, but I just wanted to end with, if anyone's interested in more information on fertility advocacy, please email Dr. Caitlin Martin, her email's here, or myself, and we can get you plugged into ways that we can get involved.
Thank you so much, Taylor, for that wonderful presentation. We will save all questions for the end, but feel free to submit them through the chat or the Q&A tool, or if you'd prefer to email them to Dr. Geisman, that would be good as well. We'll continue the morning with Dr. Ahmad Rana. So Dr. Ahmad Rana grew up in Hoover, Alabama. He went to Emory University in Atlanta to complete a Bachelor of Arts in Economics and a minor in Arabic language. He moved back to what he would say is sweet home, Alabama, to complete his medical degree. He found his way to WashU for internal medicine residency, and throughout his training, he participated in the Washington University Teaching Physician Pathway program. Dr. Rana will also be staying with the WashU family as a rheumatology fellow starting this summer. Thank you so much, Ahmad, for being here today and for talking to us about Ramadan, the holy month of fasting, and its role in healthcare.
Thank you so much, Dr. Kadiwada. Hello, everyone. My name is Ahmad Rana, and for those of you who don't know me, I am one of the chief residents in internal medicine here at WashU. I'd like to start off by first thanking Dr. Frazier, Dr. Costco, and the residency program for giving me the opportunity to speak about a topic that is of personal significance to me. Today, I'll be discussing Ramadan, the holy month of fasting for Muslims, which Muslims all over the world just finished celebrating last week, and why it's important for everyone, including healthcare providers, to understand its significance and traditions. Spirituality and personal beliefs are important to social determinants that affect patients' health behaviors and adherence to treatments. To address these aspects and to ensure delivery of culturally competent care, it is important for us to have a basic understanding of how Islamic teachings, including intermittent fasting, shape our Muslim patients' health, especially those with chronic medical conditions. By the end of this talk, I hope you'll be able to take away some fundamental knowledge of Ramadan in order to better understand the experiences of your Muslim friends, neighbors, and colleagues, and to provide effective care for your patients. I have no relevant financial disclosures for this talk. My only other disclaimer is that while I identify as a practicing Muslim, I am not a scholar in Islamic studies by any means. but I hope to provide you with some useful information today. Here's the general outline for the presentation today. First, we'll start off with some demographics regarding Muslims as part of the global and national community. Then we will discuss basic facts about Ramadan, including its origins and how it is practiced around the world. Next, we will discuss what is important for providers to know about Ramadan and how it applies to patients. And lastly, we will briefly touch on the health effects of fasting and how to counsel patients who will observe fasting during the month of Ramadan. Starting off with some demographics. So Muslims are the second largest religious group in the world, with an estimated about 1.9 billion people, or about a quarter of the world's population, who identify as Muslim from the latest available data. For perspective, the largest identified religious group are Christians, with 2.4 billion followers, which is approximately 31% of the world's population. In addition, according to the Pew Research Center data in 2017, there were an estimated 3.45 million people who identified as Muslims in the US, which was about 1.1% of the total population. And by 2050, this number is expected to grow to 8.1 million, which is expected to be about 2% of the population at the time. And the reason I'm really providing you with this data is to inform you of how significant the proportion is of Muslims with respect to the national and world populations. Additionally, Islam is the official religion in 26 countries that span Asia, Sub-Saharan Africa, the Middle East, and North Africa, which are highlighted on this map. And Islam is the fastest growing religion worldwide. This map from the Pew Research Center highlights the proportion of the population in each country across the globe that identify as Muslim, with a large proportion of Muslims in those countries highlighted on the previous map, where Islam is the official religion. So now let's shift gears from talking about Islam in general to talking more specifically about fasting in Islam. Here is the 183rd verse from the second chapter of the Holy Quran, known as Al-Baqarah, which is the scripture that initially discusses fasting. And it translates in English to, "O you who believe, fasting is prescribed for you as it was prescribed for those before you, so that you may develop God consciousness." I started off with this quote as it highlights the ultimate purpose of fasting in Islam, and that is to attain righteousness inwardly and outwardly, through self-reflection and appreciating one's blessings in life, and to obtain closeness to God. Fasting, also known as in Arabic as Sawm, is one of the 5 pillars of Islam, and along with the Shahada, or the profession of faith, Salat, the 5 daily prayers, and Zakat, charitable giving, and Hajj, the pilgrimage, these are the 5 pillars of Islam. And while fasting in Islam is most commonly associated with Ramadan, there are several other times throughout the year when Muslims may fast, but that is beyond the scope of this talk. So what exactly is Ramadan? Well, technically speaking, the month of Ramadan is the 9th month of the Islamic calendar. And this is the month when it is believed that the first verses of the Quran were revealed to the Prophet Muhammad, peace be upon him. The Islamic calendar follows the lunar calendar, which is based on the monthly cycles of the moon's phases. And lunar years only last 355 days. Therefore, one of the first takeaway points I'll give you today is that because of the lunar calendar, Ramadan moves back about 10 days every year on the Gregorian calendar, which is the calendar with which we are all more familiar. As a result, Ramadan can take place during any of the 4 seasons, depending on the year. And depending on the sighting of the crescent moon, which is the signal for the last day of fasting during the month of Ramadan, Muslims will fast for either 29 or 30 days. Over the month of Ramadan, Muslims fast between dawn and sunset, which can vary greatly depending on the season. And while Ramadan is most famously known for its association with fasting, this month is also a special time to focus on reflection, special prayers, community, and charity. Some of my fondest childhood memories include going to the mosque during Ramadan and the sense of community and breaking bread and praying with family, friends, and even strangers at the end of the day of fasting. And after the last day of fasting, with the crescent moon sighting, Muslims celebrate Eid al-Fitr, which is technically a celebration to commemorate the past month of fasting and reflection and prayer. I'd like to point out that fasting is not a unique practice to the religion of Islam. There are several examples of fasting as spiritual practice for the religions of the world. and these fasting practices differ and vary from those practiced by Muslims. Some examples that come to mind include the Yom Kippur fast in Judaism and Lent in Catholicism. Fasting also is a practice in many other religions of the world, including Hinduism, Buddhism, Taoism, and in so many more when I was doing my research. As healthcare providers, it is prudent for us to understand our patients' spiritual practices to best manage their acute and chronic medical conditions in an informed manner. So what is exactly included in the fast for Muslims? To fast from dawn to sunset, Muslims abstain from eating food and drinking any liquids. Probably the most commonly asked question we receive as Muslims about our fasting practice, to the point where there are even memes and t-shirts made about it. Yes, not even water during the fasting hours. Muslims also abstain from the use of tobacco products, as well as other listed sinful behaviors from dawn to sunset. And for the purpose of the field of medicine, Muslims who observe fasting may also choose not to take their medications during the fasting hours, which can provide significant challenges with respect to the management of particular conditions. Here's a glimpse into what a typical day looks like for a Muslim who is fasting during Ramadan. I've included some timestamps from the last day of fasting from this past month of Ramadan to help provide some perspective on the length of the day. The day starts up by waking up for the pre-dawn meal, called sahur, where people eat a variety of foods and drink plenty of water. Every person seems to have their own magic concoction and combination of foods to help them get through the fast. My mother's is yogurt. She says that really hydrates her. And then shortly after sahur ends, we pray the morning prayer Fajr, which is the first of the 5 daily prayers, which happens during Ramadan and not during Ramadan as well. Then as the day goes on, we have the 2 afternoon prayers, Zuhr and Asr. And by sunset, we have Iftar. It's time to break our fast, which is the meal where the fast is broken in conjunction with the evening prayer Maghrib. And it's very common to break your fast, as the Prophet Muhammad, peace be upon him, did, with a date, actually. Then the last of the 5 daily prayers, Isha, occurs. And then during Ramadan, there are special optional prayers shortly after the night prayer at the mosque, called Tarawih, during which the Imam or the leader of the prayer recites the entire verses of the Quran throughout the course of the month, typically getting through about a chapter a night. Some people may also elect to pray an additional prayer called Tahajjud in between the time when Tarawih ends and before the pre-dawn meal, though this is also optional. As you can see, there's a lot of time for additional prayer and reflection that occurs during Ramadan throughout the course of the day, with days for most people starting at 4 a.m. and ending at 11 p.m. in the most recent month of Ramadan. And there definitely is an impact on sleep schedules during this month as a result. So are there any exemptions? There are actually clear exemptions from fasting, as noted in the Quran, as well as in hadith, or recorded descriptions of the words and actions of the Prophet. Scholars of Islamic law have studied these religious documents for centuries and make recommendations on how best to observe Ramadan. And there are several groups that scholars agree are not required to fast during Ramadan. These groups include the elderly, people who are pregnant, nursing, or menstruating, people who are ill acutely or chronically, and those who are traveling. One caveat I'll say is there's a little bit of nuance in scholar opinion for what constitutes exemption within these groups. For example, there's variation in opinion on what exactly it means to be traveling and how far to travel, and that differs amongst the scholars. Muslims may choose to follow a particular scholar's view, so it is important to understand your particular patient's practice. A couple of important points to note are that those who are exempt can make up the fast if and when they are able to in the future, or they can honor Ramadan through charity, such as by feeding a less privileged person in lieu of fasting. So why would a patient fast if they're exempt? So some patients may choose to fast even though they're medically exempt from the view of Islamic scholars, and some of you may wonder why that may be. I'd like you to reflect on a clinical scenario that you may encounter on the inpatient wards. Consider that you have a patient with concern for a gastrointestinal bleed, and the patient presents with a significant anemia, for whom your clinical practice would be to transfuse packed red blood cells. However, this conflicts with the patient's belief as a Jehovah's Witness. While we may cite that there is support for recommended medical care in the case of emergencies, a patient's personal beliefs are important to understand with respect to their care. And Ramadan is the largest Muslim celebration of the year. Some may fast because of the spiritual rewards of fasting are believed to be multiplied during Ramadan, and others may fast for other reasons. Whatever the reason may be, it is important to have a conversation with your patient and be knowledgeable about his, her, or their beliefs. This is particularly important in our field, given that Muslim patients may discontinue medications or alter their regimens in order to fast without consulting us. And this can lead to serious complications, such as dehydration, hypo or hyperglycemia, DKA, among others. However, with appropriate professional advice and treatment plans, safe fasting can be achieved. So there's been much inquiry and research into the treatments and procedures that invalidate or do not invalidate fasting over the years. Both the Islamic Fiqh Council and Standing Committee for Academic Research and Issuing Fatwas have released guidance regarding this topic, which are summarized in the table shown. And I'd like to note that while this table reflects the opinion of those two committees, this does not reflect the opinion of all Muslim scholars. So I'll review the opinion of the Islamic Fiqh Council regarding the treatments and procedures that are not felt to invalidate the fast. And these generally include ocular, nasal, or dental treatments or procedures, given that the fasting patient does not feel taste in their throat or swallow any residue. And with regard to injections, subcutaneous, intravenous, or intramuscular, or other procedures, if they are deemed to be urgently needed, these would also not invalidate the fast according to Islamic Fiqh Council. It should be noted that if a treatment or procedure is not urgently needed, it would be recommended to take or schedule the procedure before or after fasting hours. And with regard to treatment and procedures that are deemed to invalidate fasting, according to these committees, typically it's oral medications and parenteral nutrition during fasting hours. The Standing Committee also includes deliberate vomiting and dialysis during fasting hours as practices that would invalidate fasting, though the Islamic Fiqh Council and other councils do not include dialysis on this list. And there are some Muslim scholars who believe that blood transfusions and donating blood during fasting hours may invalidate the fast. One common misconception that I would like to highlight among both Muslim patients and primary care providers is that insulin injections and monitoring blood sugars would invalidate fasting, though there seems to be an overall consensus and agreement in the research that I did amongst scholars that this is not the case. So that's something that's important to take away for your diabetic patients. And while we're on the topic of diabetes, there are an estimated about 90 million Muslims who have diabetes worldwide. And although most scholars and physicians recommend against fasting for patients with uncontrolled diabetes, a large population-based study that included patients or participants from 13 countries estimated that about 80% of Muslims with type 2 diabetes will fast during Ramadan. Luckily, the International Diabetes Foundation and an organization called the Diabetes and Ramadan Alliance collaborated to create comprehensive guidelines for fasting patients with diabetes. These guidelines classify diabetic patients into 3 different categories: very high risk, who are not recommended to fast; high risk, who are also not recommended to fast; and moderate to low risk, where patients whose diabetes is well controlled. But you may have patients who choose to fast amongst all 3 categories. So here's a table outlining those risk categories with respect to the patient characteristics and recommendations for these diabetic patients from these committees. Patients who are very high risk include those who with severe hyperglycemia within the last 3 months, recurrent hyperglycemia, the elderly, or stage 4 CKD or greater. Patients in the high risk category include those with well-controlled diabetes who require multiple doses of insulin throughout the day, those who have poorly controlled type 2 diabetes, and those with stage 3 CKD. And low to moderate risk include those with type 2 diabetes, which is well controlled with lifestyle modifications, oral agents, or basal insulin alone. For all of these patients, they should undergo structured education and counseling on appropriate dietary intake, as well as adequate hydration during fasting days. In addition, all patients should check their blood sugars regularly. And for those with high risk or very high risk diabetes, they should discuss with their PCPs and specialists on how to check their blood sugars during fasting. Patients with very high risk or high risk diabetes are recommended to break their fasting immediately if their blood sugars are less than 70 or greater than 300, or if they become symptomatic from hypo or hyperglycemia. In addition, these patients should be counseled on the warning signs of hypoglycemia and what should be done if any of them occurs. Furthermore, patients should be advised to eat healthy, balanced diets in small 2 or 3 meals between iftar and suhoor, which I can say from personal experience is hard to do. It's very common for people to eat very large meals, especially when we're breaking our fast. But this can be a particular risk for these patients with one large meal, as it could promote post-meal hyperglycemia. And modifying the dose of diabetic medications is an essential component of managing patients with diabetes in Ramadan. And there are actually really detailed guidelines from the International Diabetes Foundation regarding how to adjust the dosing of oral agents and insulin, including pumps, for those who choose not to utilize medications during fasting hours. I'm more than happy to provide those who are interested with these resources if you reach out to me after the talk, but would also recommend that your patient have a discussion with a specialist. Now to transition to the health effects of fasting during Ramadan, starting with the cardiovascular effects, which have been pretty thoroughly studied. A recent systematic review and meta-analysis showed that fasting during Ramadan is not associated with the risk of developing acute cardiovascular events, which was a theory that had been proposed previously. And while some studies that fasting during Ramadan results in reduction in total cholesterol and LDL-C levels and a slight decrease in triglyceride levels, the evidence about the effects of fasting during Ramadan on the lipid profile is inconclusive. And these have been several observational studies that have been done. There's also similar data about glycemic control and improvement in A1C in observational studies, but again, the data is not completely conclusive. And also, it has been shown to be safe for patients with controlled high blood pressure to fast, and it is recommended that they still consult with their PCPs a few weeks before Ramadan to adjust their medications if needed. In general, longer-acting antihypertensive medications taken at both the pre-dawn and breaking fast meals are the best strategy to manage hypertension in fasting patients. However, an important consideration is diuretics are not recommended as a new antihypertensive regimen, especially during summer months when Ramadan is occurring. For patients with renal diseases, fluid restriction and the possible dehydration during fasting becomes a concern. There are a few studies with inconclusive results that are available on the effect of fasting on chronic kidney disease, but many physicians are concerned that fasting can cause further progression of CKD. Therefore, a careful assessment and continuous monitoring of the kidney function should be performed before and during Ramadan to determine the ability of patients to fast. And although one study showed an increase in hospital admissions due to renal colic during Ramadan, other studies have failed to prove such an association. And the evidence about the role of fasting in Ramadan in inducing renal stone formation is also inconclusive. However, it should be recognized that these studies may have been conducted when Ramadan occurred during the colder seasons rather than during the summer months. Despite that, almost all studies and physicians agree on the importance of drinking adequate amount of water and having an appropriate diet in patients, particularly in those with a history of renal stones. Studies have shown that fasting during Ramadan is safe for patients who have been recipients of kidney transplants and if their graft function is acceptable. Immunosuppressive medications, luckily, when prescribed, can be divided into 2 doses for them to take at the pre-dawn meal and at the meal to break fast with R. And just to end with some general advice for patients who elect to fast during Ramadan, one would be to ensure that they're adequately hydrating and maintaining a well-balanced and healthy diet rich in fiber and low in salt. And for those who desire to exercise during Ramadan, to do so after sunset and not during the fasting hours to reduce the risk of dehydration. Here's a nice infographic for healthcare providers with tips on how to care for patients in a culturally competent manner during Ramadan that I think is very useful, and it was published by providers at the University of Waterloo. And things that I'll highlight from this is that the first and the utmost important thing to ensure and have a conversation with your patient about is whether or not it's safe for them to fast. So there's other ways that we discuss that patients can honor Ramadan if you feel like it is not safe for them to fast. Now, patients may elect to still fast, so then at that point you'll have to have a conversation with your patient about ways to be the safest to do so. Important considerations, especially as a provider, are adjusting the time of medications and the types of medications. The example they provide on this infographic are choosing antibiotics that are taken only once or twice daily to comply with the patient's ability to take it with the pre-dawn or breaking of the fast meals. And Another consideration that I like that they highlight in this is adjusting the fast. So if someone cannot fast over a long summer day, like I mentioned earlier, you can make up fasts at different times during the year. So if your situation changes and you are able to fast at a later date, you can make up your fast during a shorter winter day later in the year. And underlying all of this for your patients is considering their comorbidities and illnesses, encouraging patients to eat sahur and to stay hydrated and adjusting doses as needed. So I just wanted to end with this email that we received as employees of Barnes Jewish Hospital this year from BJC Language Services that I really appreciated with respect to its depth of pertinent information for employees and considerations for both Muslim patients and coworkers. It was a clear effort from our institution to promote inclusivity, and I hope to continue to see more efforts such as this one in the future for all religious and cultural practices for our employees and patients. So to summarize, you have Muslim friends, coworkers, and patients. Fasting in Islam includes abstaining from food and drink from dawn to sunset, including water. And there are several exemptions and opinions about what does or does not invalidate the fast to be aware about. There are important considerations for your patients during Ramadan depending on their comorbidities. And most importantly, have a conversation with your patients. Understand what their practices may be, as they can vary differently even within Islam itself. So it's important to understand what your patient's experience will be during Ramadan, as well as to be educated on at least basic tips and opinions of committees of what may invalidate or what may not invalidate the fast, or what may exempt some certain patients from fasting. So I hope this talk provided you all with some basic knowledge of Ramadan and will be useful for your care for patients in the future. Here are my references. I'd like to thank my parents, my sisters, my wife, Mariam, who helped me practice this talk, Dr. Frazier's, Dr. Costco, my co-chiefs, my former co-residents, and the house staff. And then these are just some pictures from the Eid celebrations here in St. Louis. Prayer was at Queen Park outside to comply with social distancing guidelines. And this is my family and my wife's family, and then my sister's. With that, I guess I will open it up to questions.
Thank you so much, Dr. Rana, for going through that with us. We will go ahead and proceed to the question and answer session. We can go ahead and start with a question for Dr. Geisman here from Dr. Frazier. So Dr. Frazier asks, what system level changes would be helpful to demonstrate support for women in childbearing years to enhance their comfort with pregnancy planning and/or infertility awareness?
Thank you so much for that question, Dr. Frazier. I think there's a few different parts to that question. I think the first area that we can focus in on is education, integrating this into medical school curriculum, but also integrating fertility knowledge into residency education too, just to raise awareness. I think the next part that we can think about is improving access of the residents to fertility counseling and fertility treatments, whether that goes through, increasing fertility coverage, adding elective egg freezing onto it, or even, including fertility counseling in with like primary care, essentially covering that. Maybe every resident gets an opportunity to meet with REI for fertility counseling to discuss egg freezing and family planning. And I think the final area that at a system or an institution level would be to make formal policies around paternal and maternal leave. And being able to have set policies in place program by program with how coverage will work and whatnot, just to help relieve some of that stigma associated with leave as well. I think those are areas that we can start focusing in on. And I think WashU actually has done a good job at integrating some of those into their policies as well.
Great, thank you. My next question is, can you clarify what restrictive and non-restrictive meant for the benefits that you had listed at the end of your presentation?
Absolutely. So in terms of Washington University fertility coverage, what I mean by restricted is that you can utilize that coverage at the Washington University reproductive endocrinology and infertility clinic, and not at any other clinics, versus Barnes. When I say non-restrictive, that means you can utilize those benefits at any fertility clinic.
Thank you so much, Taylor. We'll move on to a few questions for Dr. Rana here. So the first question we have here is from Dr. Fondon, one of our APDs. She asks, what should training programs be cognizant of for trainees who may be fasting?
Yeah, I think that's a really good question. And I think, generally, I think it's just important for training programs to understand which residents may be fasting. The timing and scheduling, a lot of residents or fellow Muslim trainees who've done internal medicine have preferred to actually be on night float rotations during Ramadan, just because you can eat during that time. It can get a little bit tricky with sort of responding to calls during that time and getting the timing of all the prayers. But if they could be on elective rotations or not inpatient rotations during that time, just given as you could see, especially during the summer months, the days can get really long during Ramadan, especially if somebody's practice is to go to the mosque for the night prayers, and that's part of their daily practice during Ramadan. So it can become a little bit challenging. So maybe just being a little bit cognizant of those residents. And then this is beyond Ramadan too, but Friday prayers are in the afternoon, but particularly of importance during Ramadan too. So I have actually talked to Steve about this too, but sometimes we get scheduled for things like, if we're on clinic, like afternoon clinics and certain things like that. So just being a little bit more cognizant about that during Ramadan can be really helpful as somebody's trying to develop their spiritual practice.
Awesome, great. And then our next question is from Dr. Frazier. She says, that was a terrific talk. Are there other cultural and/or religious aspects of the Muslim faith that healthcare providers should be aware of to improve healthcare and equity for Muslim patients?
Yeah, I think kind of something that kind of from the last question as well, the answer from the last question as well, just being cognizant of, prayer times. The daily prayers actually don't take very long, so like 5 or 10 minutes. So just appointment times, just being a little bit more flexible with that and just being cognizant of that, I think would be one thing to improve outcomes. Practices of Islam are vary greatly from person to person. Even for people who classify as I identify as a Sunni Muslim, but a fellow Sunni Muslim can have different practices. Things that have come up for me, particularly on inpatient services, is I know like heparin can sometimes say it has like porcine injection. And so some patients are very opinionated about, it says that, I don't want it, even though that, many Muslim scholars have said that that's not necessarily true and you can get it and that sort of thing. So other than medications and, what they may be coded in, that's one of the main things that has come up for me as a provider. Otherwise, I think just being knowledgeable about these basic facts during Ramadan is what would be really important.
Great. Thank you so much, Ahmad and Taylor, for your wonderful presentations this morning. It was a great way to kick off kind of this end of Grand Rounds period currently. I will go ahead and share my screen to give people credit for being at conference today.